Thank you so much, Jenny, for this invitation, and thank you all for sharing your Saturday with us and coming here. So we'll talk about transplant. I think we had really fantastic talks this morning discussing the data, but in clinical situations, we'll ask the experts what they do and how they discuss this with patients. So we have a 63-year-old female with ISS stage 2, RISS stage 1, free kappa light chain myeloma with bone marrow plasma cells 60%, normal FISH panel, so standard risk cytogenetics, with anemia and lytic bone lesions. The patient got the Griffin trial DARA RVD regimen, but got this for 6 cycles. And patient would like to avoid transplant if possible, and I think many patients do ask that. But what happens after the induction therapy when the patient had a bone marrow, the bone marrow had less than 5% abnormal plasma cells with normalization of the free light chain ratio. So the patient has achieved what we would call an MRD positive complete remission at the end of induction. And in this situation, maybe we can go each of you and answer like what you think. One is, would you tell all patients in such a scenario to do a transplant? What would be your recommendation? In which scenarios you think it's okay for them to avoid a transplant, and why you would say that? And I'm sure we might have a little different answers, but I think that's part of the discussion. So maybe Dr. Gasparato, do you want to start?
Sure. Well, first of all, I will collect the stem cells no matter what, even if the patient, and I will explain why, because it's the best timing, right? Collecting the stem cells when you achieve close to a remission and you have a clean bone marrow and you can utilize the stem cells later. And then a very important factor will be, is the patient tolerating therapy okay, right? I'm not ready to stop therapy yet. We talk about the fact that this clone is not probably moving very rapidly and it takes a little bit of longer time to kill. But I would go a little bit longer to try to achieve the MRD negativity at least. And everything has to do with tolerability. If the patient is doing phenomenally good quality of life with the regimen and she's willing to continue a little bit longer, I would probably chase that. And I go back and forth with the transplant, and a lot of time I put myself in the patient situation. And if I had myeloma, if I was in a situation, will I do the transplant? And with the data that I have so far, and I'm always evolving and changing, I probably will, because if I'm MRD positive, I will be a little bit uncomfortable. I want you to give me the MRD negativity and keep me there. But I respect the wishes of the patients, and I respect the fact that transplant may be kind of overwhelming for some patients. So I will collect the stem cells, continue therapy, and revisit, every so often.
Dr. Kaufman?
So when I see this patient, young, healthy, standard risk disease, tolerated therapy, and asks the question or says, I'd like to avoid transplant if possible. And then the other factor that I put in here is that it's MRD positive, so incomplete, had a complete response, but remains MRD positive. I would say that if somebody is MRD positive after 6 cycles of DARA RVD, it's probably very unlikely that with these same drugs that they're going to convert to MRD negativity. It's a low amount. And so in my mind, if I'm thinking about 10-year survival, 15-year survival, 20-year survival, I'm thinking that there needs to be a further death. And I would say to the patient, so the way to increase your chance of staying in remission for the longest period of time and I believe, this is what I know, what we know is that transplant is associated from a population perspective of staying in remission longer. We all know that. There's nobody debates that today. What I believe is that this is ultimately going to be associated with improved survival. What I know and what I believe. And I would say we can do that, but I think you'll very likely relapse earlier. And so I would recommend a transplant for this patient.
And Dr. Duckman, anything to add?
I would agree with my colleagues in general recommendations. I think that based on what we know today, and I guess I would highlight 2 points of data which I think are relevant to this discussion and which my colleagues have alluded to. First is that the data are in flux, and currently we don't absolutely know what the right answer is and how to manage this situation. What I would say is that, as Dr. Kaufman's saying, it's pretty clear that doing transplant will likely keep myeloma in remission, so under control for longer. Based on everything we know now, the most recent studies, it's quite likely that it will keep myeloma under control for longer. But we also know that keeping myeloma under control for longer is a good thing, but it's not the end-all be-all, and that the things that we really care about are how long we live with this and how we feel. And so, that's what's still much more up in the air about transplant in 2023. At this point, it's not totally clear that transplant certainly doesn't help you to feel better, at least short term. We know that. That's the one certainty. And whether it helps people to live longer, it may not. I agree with Dr. Kaufman. It's quite possible, but we don't clearly know that as clearly anymore. So what I do is typically encourage people to have a transplant in a situation like this, but I do think that banking stem cells and keeping the transplant in our back pocket for later is a very appropriate thing. And then the second thing that I would point out as far as a gap in the data goes is this MRD thing. So for those that don't know, MRD is minimal residual disease. It's just basically a test that we can run typically on bone marrow. It's one of the most sensitive tests we have for detecting very low levels of myeloma cells in the bone marrow. And so we're starting to use MRD data to make treatment decisions. Basically, if it's positive, we know that there's myeloma still there. Should we keep therapy going? Should we intensify therapy? And then conversely, for people whose bone marrow is MRD negative, could it mean that some people are cured? Can we de-escalate therapy? Can we basically give people a break? We're starting to make treatment decisions based on that, but this is more based on sort of impressions as opposed to hard clinical data. The studies that are going to really tell us what's the right thing to do with those data, those studies are ongoing now. Will take years to read out, and so as you're hearing, we do different things with those data, but I point out that this is still a very controversial area without a lot of concrete data behind it.
So to summarize, what I'm hearing is that all experts here feel like a transplant upfront is a good idea. It improves progression-free survival, not clear about overall survival if you do a transplant later, but if you never do a transplant, probably may affect survival. And then another thing we heard was maybe if somebody's still very, very resistant to transplant, could we talk about doing a few more cycles of DARA-RVD to see if we achieve an MRD negative response? But the chances are low, as Dr. Kaufman pointed out. So knowing this data, each person might individualize to what they think is right for them. And then I think the last thing, that we could also ask it, and patients might want to know is, if I'm getting a transplant and you're saying I'm going to stay in remission longer, how much longer is that, and how much time am I going to take to recover from the transplant? So is this worth the time for me to spend getting better or staying in the, getting admitted, recovering from the transplant compared to the time I'm going to stay in remission longer? And I think that answer is different for everybody. And maybe we can just quickly talk about that in terms of the numbers that we've seen with the IFM study and with the determination trial, which we heard from Dr. Gasparro earlier today. So it's about 14 to 20 months. Maybe if you all want to add anything to this summary.
Yeah, I think that's sort of the time frame of improvement, more somewhere in the 1 to 2 year improvement. I think it's hard to understand what an average of 1 to 2 year over a population is. I think more like the likelihood of being about 50% of the patients are going to remain in remission 5 to 6 years later. That's about versus maybe 30%. So there's a significant, you're much more likely 5 years from now to be in remission. So that's how I try to explain it, because it's a little bit hard to understand what is 12 to 24 average over a group of patients. So it's really about the likelihood of being in remission at 5 years and 10 years. That's how I think about
That's a great point. And I think I think that we'll conclude this case with that. But this is, sorry, let me go back.
But can I answer the sort of the second part, is how long the recovery is? And I think the determination trial very clearly, there was documentation of quality of life, very clearly showed decreased quality of life during the transplant. But by 6 months after transplant, in a large part, they're very much the same. So I would say about probably 80%, and this is not hard data, this is my feelings, 80% of patients by 6 months after transplant are essentially back to their normal activity, or the equivalent of what they would have had without the transplant. And then 95% of patients by a year. That still means that I have 5% of patients a year after transplant who still are having side effects from transplant that I can't explain.
And also to know that transplant works for the majority, but it doesn't work for everybody. So some patients go into transplant thinking their myeloma will, they'll definitely, if they're MRD positive going in, they're going to come out MRD negative. And there are patients who may go in MRD positive and come out of transplant MRD positive, and they're obviously very disappointed. They went through 3 months of it. But it's just important to know that we don't have personalization yet, where we know that whether melphalan's going to work for your myeloma or not. We know it works for the majority. We know it deepens responses. And so that's why we're telling patients to do it. But that's the challenge and the area that we're not able to, tell you. We don't have a crystal ball to say, are you the one who's going to respond? But the majority will. And then this is exactly the same case, but the response is slightly different. And I wanted to see if you all would change your answers. But again, this patient had end of treatment bone marrow with no residual disease. And this time, they had testing by next generation sequencing and next generation flow. So these are different ways of testing. And we can talk a little bit about that too. Flow cytometry, it looks more at a depth of 1 in 100,000 cells usually. And it's dependent on which site or where you're doing it, if they have a good flow testing facility, because not all places have it. And then the next generation sequencing is more like an FDA approved test, and it's available almost anywhere now in the US. And that is 1 in 1 million cells. So it's much deeper as a response. So when you're looking at studies, you're also looking at how deep was the response that they assessed when they're talking about MRD negativity. And that's a moving target too. So this patient achieved the best kind of response after 6 cycles. And in this scenario, because as we talked, transplant upfront is standard of care for myeloma. Is it standard of care for a patient like this? And would we still recommend it? And maybe Dr. Tuckman, you can start this time and we go the other way.
Yeah, I think, again, this is a really complicated and controversial area in the sense, as I alluded to earlier, we don't have a lot of concrete data on what to do with this. But determination and others, so the study that we've been talking about and others have suggested that if people achieve MRD negativity without a transplant, that outcomes are similar to the people who do have a transplant. That probably, so in some sense, it may not matter how you get to MRD negative as long as you get there one way or the other. But again, that's not concrete data. There's never been a study to look at people specifically who have achieved this situation, say MRD negative after standard induction, have not yet gone through a transplant. Right? Ideally, you'd have a study that takes half of those people, takes them to transplant, the other half don't go to transplant, and then 10 years down the road, you see who lives longer. That study may never be done. But I think right now, sort of along the lines of what Dr. Gasparetto was saying, a patient who is really not enthusiastic about transplant in general, at the MRD negative state, I think the benefit of transplant is probably even less, so we can be less confident about the benefit from transplants. I would be very comfortable and probably recommend that we just bank stem cells and keep transplant in our back pocket for later. But I don't think it would be wrong to have a transplant in this particular situation.
So what I've learned about patients whose preference is to avoid transplant is that their preference will always be to avoid transplant. And you saw that in the determination study, where only 1 in 5 patients who relapsed went and had a transplant. And that's my experience. And so the way I see it is that no matter that transplant is an effective therapy. it remains an effective therapy. I think you said it. It's not magic. It's not a cure, but it is an effective therapy. And so this, in a large part, doesn't change what I say. We have, and I think it's reasonable to what Dr. Duckman's point was, but we have less things to measure because there's nothing, we can't make this better. But it's but my view of the data is that transplant remains effective, and while we will go ahead and collect stem cells, the stem cells will very unlikely ever be used for a transplant.
I agree with them. I think that the MRD, how we measure the MRD is not perfect. And so, maybe the MRD that patients achieve after transplant is better. And we do have some studies showing that. I was alluding this morning to the Forte trial that was presented by the Italian Francesca Gay. She was comparing a different triplet, the carfilzomib for 12 cycles, I believe, versus a short course of this triplet followed by transplant. And when she and there was a third arm I'm not talking about, but when she presented the data 1 year, she presented at ASH, she showed that the number of patients achieving MRD negativity in these two arms was the same. So when we left the room, we were like, well, maybe we don't need transplant, and maybe we just do continuation of therapy. When the next year, the following year, she gave an update of the study, and she showed clearly the patients who had achieved MRD negativity with transplant were doing better. Patients who had achieved MRD after continuation of therapy, they were progressing. Not all of them, but there was a higher rate of progression. So again, we left the room and say, well, what that means, that the MRD was a better quality. That's the reason why we were talking about sequential MRD. And so, and we started to see the IFM that I showed this morning. The Stamina is another trial coming from the US where we compare one transplant, two transplant, one transplant with consolidation. And there was no difference between the three arms. However, the number of patients achieving MRD after two transplants was better. And so the question is, what's happening in the future with that study? Are we going to see a survival signal? So for now, like I was saying this morning, and like Sasha and Jonathan said, we don't have the data, but we know that transplant helps you to achieve a deeper response, right? And that's bottom line, keeping the clone from coming back too soon. And so maybe the CAR T-cell will change, maybe the bispecific, which we'll all hope. We want to get out of the chemo. We don't want to give you chemotherapy. That's the bottom line. We don't. We hate to see you struggling, losing the hair, and that 3 weeks in the hospital. But it's still working. And that's the reason why we still recommend it, because we see this data and we say, you're going to be in remission 5, 6. I had one patient 19 years a couple of weeks ago, and we do the 10-year survival and plus. And so we know that that patient has everything available, right? Because over the last 19 years, everything became available. She was treated with VAD, if I recall correctly. And so if she progresses now, my gosh, it would be a matter of deciding what to do. So you freeze your myeloma, and during that 5, 6 years, 7 years period, more stuff, more understanding. So I think right now I will do it.
Great, thank you. I think that was a good summary. We'll go to the next case. This is maybe more straightforward, but more complicated too. So this is a 74-year-old male with a very unusual kind of myeloma, non-secretory myeloma. I saw this patient in my clinic actually with creatinine 1.4 anemia, so really had a pancytopenia, and there was evidence of minimal bone involvement. The bone marrow plasma cells on the outside biopsy were 80%, and the patient had kappa light chain restriction in the bone marrow, but in the blood it looked like all normal markers, so you couldn't tell anything from blood markers. So this patient had ISS stage 1 RISS stage 1 standard risk transplant eligible non-secretory myeloma. The patient was extremely fit, used to exercise regularly. So even though he was 74, he was very fit. And then at that time, we decided to do the standard induction with RVD. However, in the first cycle, he had major, side effects to the Velcade with GI issues, which were, it's unusual to have this severe issues, but he did. And so we had to really think about what to do next. And we thought like maybe daratumumab would be a better tolerated drug. And so we switched over the next month to daratumumab and treated him. However, through that time, his count still remained pretty low. And since it's non-secretory, we decided to repeat a bone marrow biopsy to see, is he responding? And yes, his bone marrow plasma cells went down from 80% to 40%. So that's about a 50% reduction, which is good. But we also, this first bone marrow in 2020 was done outside. So we had a normal FISH panel, but that wasn't done at our institution. So we repeated the FISH panel and we see that he has a translocation 1114 in 63% of the cells. And so we decided to continue with the dara, Revlimid, dexamethasone because he was responding. However, he developed these fevers and we needed to admit him because the fevers were really high and we didn't know what's going on with those fevers. He had a very thorough workup. Nothing was found. And then we repeated a bone marrow biopsy during that time just to see, is it the myeloma causing the fevers? And it looked like it had improved again. So we just continued the dara, Revlimid, dexamethasone. However, during that repeat bone marrow biopsy, we did some genomic sequencing to look for genetic changes in case there was something else going on with these low counts and everything. And we saw there was a TP53 deletion. We continued the dara, Revlimid, dexamethasone, but he continued to have these fevers and severe fatigue. So he really wasn't doing well on it. And it was hard to stop treatment because of his aggressive disease. And the fevers would go and then come back. So we were still struggling with what's going on. So we repeated another bone marrow biopsy because we said, this doesn't make sense that he's having so much fever, the counts are low and all of this. And actually the bone marrow had 80%. So he actually progressed on the dara, Revlimid, dexamethasone, and he wasn't responding to it. But that bone marrow biopsy actually showed a 17p deletion in 13% of cells and also a translocation 1114 now in 97% cells. So he had transformed to a high-risk myeloma through this time. And because he was not responding to dara, Revlimid, dexamethasone, and we were not able to collect his stem cells because he hadn't really responded yet to collect the cells, we decided to do intense chemotherapy, which is a combination which some of you may have heard of, called DCEP, which is a combination of 4 drugs, and the patients usually get admitted for 4 days. We did that, but there are some patients very rarely that it's difficult to collect stem cells. So we were not able to collect stem cells despite giving him these 2 cycles, and his bone marrow plasma cells came down again by 50%, but really not low enough where we'd like them to be for collection. However, his course was also complicated in this situation by a fall, hip fracture, ICU stay. However, the good thing is he recovered from all of this, and now he's on the other side, was asking us, what will we do next? So I will ask the experts, what do you think you may do next in this situation, and why?
We start like that. So if I start, first of all, a very difficult patient when they don't have a secretory marker because the only way to monitor is with the bone marrow, which is difficult to assess. The 11-14 marker is very important here, is driving a little bit. And actually, I have to say, I have a similar patient. Actually, she was more later line of therapy, failed multiple lines of therapy, and she also had 11-14 and the deletion 17, and a very aggressive relapse. And I rescue her and I kick her butt. She was 70 plus, and I also give her chemotherapy. That type of chemotherapy is just a bridge. We use it to bring you to the next therapy when we have to decrease the tumor burden very quickly. But it's sometimes more intense than transplant. And then I was able to put her on the clinical trial on venetoclax, single agent, and she got 1 year of beautiful quality of life, phenomenal. So she had the 2 marker. So now I will probably do carfilzomib venetoclax, your study, because you're targeting the 17, and then you have the venetoclax. But I remember that patient, because she ended up unfortunately to die, but that year of venetoclax by mouth is a pill. She had the best quality of life.
Yes.
And so it's one of the story of the patient that we were talking with each other. You see this story and you can't believe it. So I would probably go with the carfilzomib venetoclax.
Okay, yeah, I don't have that as an option here, but we could consider that. And any other different options? We'll try to wrap this case up in 2 minutes, so anything else?
I choose E, carfilzomib venetoclax.
Did the fevers get better with the DSEP? Fevers are gone?
Yeah.
Yeah, I mean, I would probably do just venetoclax, and to be clear, I think carfilzomib venetoclax would be very reasonable. I would just be, my only hesitation in giving that combination is that carfilzomib can be a tough drug to tolerate. You know, patients are coming into clinic a lot. In terms of symptom burden, it's probably tougher than a lot of the other agents that we have, even if just given once weekly. And in this patient who has clearly been through a lot recently, I would be really, so I mean, my patients in the room know that we often talk about this. You know, how likely is whatever we're doing how likely is it to control the myeloma, and how likely are we to cause bad side effects?
Well, you
I think
have
in
a
this
response
situation,
of 90%.
right?
He has a response of 90% with carfilzomib venetoclax.
Oh yeah, I don't disagree. I think that it's
Yeah.
probably more likely to control the myeloma. But in this case, you know, the myeloma is already responding to therapy. I'd be concerned about additive toxicity by adding carfilzomib. So I would probably just do venetoclax at least to let the person bounce back, just given that you mentioned that he or she is still frail. But to emphasize, I think adding carfilzomib would be completely reasonable.
Yeah, I think all of those are very reasonable options. We, you know, of course, you all have not seen the patient too, but the patient had significant weight loss and, you know, frailty from all of this, you know, fevers, ICU stay and everything. So we decided to go with venetoclax single agent at that time. And I think it would have been reasonable to add carfilzomib later once his strength came back. But he started venetoclax, and we did a bone marrow 2 months later with no myeloma in there. He achieved the best kind of response.
I was right.
So the mutations were no longer detected. But this is an example of how our standard therapies didn't really work for this patient, but targeted therapy worked really well, and something to think about. So, you know, hopefully we get there in the future with more targeted options as we, you know, think about myeloma. And I think it's starting to, there are trials looking at 414 and drugs for that and things. So we will get there, but it's going to take some time.
Yeah, exactly. That's the issue. Yep.